I'm an oncologist in Bristol in England, and like most of us, we do more than our job. So I'm a tutor and a teacher, and I sat on the European School of Oncology's working party on access to innovation in cancer treatment. How do we get more healthcare for our dollar? And it's as applicable in Australia as it is in England, as it is in any country. There isn't a country in the world, rich or poor, for which access to affordable therapy isn't a concern these days. So it's about basing health technology assessment around all you do. So you have a drug that's effective but expensive. That's a challenge. It's often held back for the people with the most severe disease. It's restricted in some way. So you'll know that in Australia there are restrictions about many high-cost biologic drugs. They're used for people who are just a subgroup of the people who could benefit. If we could make them more affordable, it'd be good for everyone. Absolutely. When you come to me as a doctor, you go, well, come on, Paul, what's the risks and benefits of this treatment? And I have to go through it. So when you talk about a biosimilar, this is a drug that does nothing that the original drug didn't have. What's the advantage? It's economic. It pays back to the health system, it makes your insurance, it makes your taxes less in the future, or it enables more people to get treatment. I mean, people worry that less cost means less good. And that's certainly not true. So all that we know from well-regulated countries is that biosimilars are similar in action, dissimilar in price, and their most important role is in increasing access to treatment. The opportunities of biosimilars are enormous. If you can increase fivefold the access to treatment with no more drug budget, it makes a big impact. Let's give an example about what biosimilars could do from the English NHS drug budget, for example. So the second wave of biosimilars are biologic anti-inflammatory drugs. And these are drugs that are transforming illnesses like rheumatoid arthritis, the inflammatory bowel disease like Crohn's disease, and ulcerative colitis. And in the UK, because these are common conditions, if you look at the spend on our specialty drugs, of the top 4 spending drugs, 3 out of 4 are these disease-modifying anti-inflammatory drugs. And suppose I could secure a discount of somewhere between 30 and 50% on those high-cost drugs. That would give the NHS in Britain the equivalent of savings of around 3 to 3.5% of its total drug budget. Now, telling people I could save £200 million isn't helpful, but let me put it into a context that you might understand. That's the salary of 9,000 new nurses. And nurses save lives as well as medicines. Why wouldn't clinicians do something that seems so obviously good? The drug regulator for Australia, TGA, has said quite clearly, biosimilar drugs have no clinically meaningful difference from the originator drug. A patient wouldn't be able to tell whether they're on one or the other. The risks and benefits are the same. So it seems strange to me that a drug that, for example, is now 96% of infliximab sales in a country like Denmark should be, after 1 year from launch in Australia, only 3% of sales. So what is it that doctors in Denmark, for example, know that doctors in Australia don't know? And it may be that they're hesitant because of worries about this class of drugs, safety. But you know, drugs like infliximab have been studied. The ACR meeting last week in America, the American College of Rheumatology, could show meta-analyses with more than 12 trials of switching between originator and biosimilar versions of these drugs, and none of them show a problem. Governments have a very clear role. Governments take your tax dollars and they take your insurance, and they want to ensure the most care for the most people. So governments are very clearly aligned. They want doctors to use equally effective but less expensive drugs, be they generics or be they biosimilars. Traditionally, medicine's been led by doctors, but the cost impact, for example, 3 to 3.5% of your national drug budget, is so great that I worry that if doctors and pharmacists don't lead on this, they will have to be led. So they could, for example, follow the use in America by patient co-payment. So they've told insurance companies that they're allowed to do this. If you have 2 equally effective drugs and one costs more, you ask the patient to pay the difference. You could follow the model in Denmark. So Denmark offers to reimburse hospitals and departments with the least expensive version of a drug. Now, if a hospital chooses to do different, it can either get the money from the patient or pay it from its own funds.